The intraligamentary injection is a very useful injection for anesthetizing any tooth or multiple teeth. Maxillary teeth have two injection sites, the distal buccal and then the mesial buccal. On the lower teeth, we go to the lingual. So on lower teeth, the injection sites are the distal lingual and then the mesial lingual. On lower anterior teeth that have short roots, only one site is needed, usually the distal lingual of these four incisors. This injection is different than the traditional PDL injection in that we're not going to use force or pressure to force the anesthetic down the PDL space to the apex of the tooth to get a short duration of anesthesia. Instead, we're going to put the needle into the sulcus and move it down until we reach resistance and then let the anesthetic flow into the bone around the tooth. So in order to do this injection on maxillary teeth, we find the bevel of the needle and approach the tooth at about 45-degree angle. We put the needle into the sulcus and then start the flow of the anesthetic by hitting the foot pedal and waiting till the voice says, "Cruise, take your foot off the foot pedal." Now the instrument is on cruise control. We move the needle down until we reach resistance. Holding the needle very, very lightly, we will feel the bottom of the sulcus. At that point, you stop and wait about 10 to 15 seconds until the DPS lights and sounds begin to start. When we hear any of the sounds, we stop and hold the needle in place. How much of the anesthetic do we deliver depends on the tooth that we're working on and the drug that we're using. If you use lidocaine, you would put half a cartridge on the distal, and then when you're ready to remove the needle from the tissue, you hit the foot pedal and go into aspiration. Aspiration starts and it's 6 beeps. In the middle of aspiration, you take the needle out of the tissue and see how much anesthetic comes out of the needle. The DPS lights and sounds are telling you that you're in the proper spot, but they will not tell you how much pressure you put on the needle to maybe block the flow of the anesthetic from going into the bone. We can determine that by watching how much anesthetic comes out of the needle at the end of the aspiration. So once again, if I delivered, let's say, a quarter cartridge of articaine or a half a cartridge of lidocaine, I then hit the foot pedal all the way to the floor, release it, aspiration starts. Beep, beep, beep. 1, 2, 3, take the needle directly out of the mouth. And then as the aspiration finishes, watch and see how much anesthetic comes out of that needle. It should be a drop or two. That's perfect. Where'd that anesthetic go? It didn't come out. It went into the bone. You're going to have really good anesthesia. But if you take that needle out during aspiration, and when aspiration finishes, you see 10, 20 drops. You see a steady stream of anesthetic coming out of that needle. Then that anesthetic did not make it into the bone, and you're probably not going to get sufficient anesthesia, at least for the duration that we would expect, which is approximately 1 hour worth of profound anesthesia on the tooth and on the tissue. On the maxillary teeth, what about the palatal tissue? What about the palatal root? We don't have to do anything. If we put half a cartridge on the distal, then put the rest of the cartridge of lidocaine on the mesial, that tooth is anesthetized for extraction, endodontics, crown, anything you want to do. There's no need to do anything on the palatal tissue and on the palatal root. That area is also numb from that one injection. On the lower, this handpiece is really too big to get into somebody's mouth. So what we do is we tend to break the handpiece short. As you can see, there's tubing that comes out of the channel in the one handpiece. You pull that tubing out all the way down, and you'll see a little notch about this area of the handpiece. Place the tubing away from you, and then just snap this short. Now you have a short-handled needle that gives you access anywhere in the mouth, okay? The next thing I do is find the bevel of the needle, that flat spot, and bend the needle just slightly, maybe 5 degrees towards the bevel. So you can see that there's approximately 5-10 degrees of a bend towards the bevel, which allows us to see where the bevel is in the mouth when we're doing the second stage of the injection. So if I was to numb this lower first molar, I would approach the tooth holding this very, very lightly like a endophile. Approach the tooth at 45-degree angle from the distal, going across the tooth. So the flow is going diagonally across the tooth. Hold this lightly, and then as you start the flow of the anesthetic, you move the needle down until you reach resistance. Then after 10 seconds or more, you're going to hear the lights and sounds of the DPS come on. Hold the needle lightly. Do not put pressure on the needle, trying to make the lights go past yellow or red. Do not put pressure on the needle to let the lights go all the way to green. That's probably going to be blocking the flow of the anesthetic so it does not drip into the bone. You hold the needle in place and you deliver the amount that you want to give. And normally we recommend a half cartridge of lidocaine. And if you're using articaine, 1/4 of a cartridge of articaine. When you hear the sound of the instrument telling you how much anesthetic you've delivered, for example, 1/4, you hear beep, beep, and gong, that means 1/4. And beep, beep, gong, gong means a half. You need to pull out. So once again, when we want to pull out of the tissue without getting anything into the patient's mouth and determine how much pressure we put on that needle, we hit the foot pedal, release it. It goes into aspiration. During aspiration, after the 3rd beep, we take the needle directly out of the tissue. So it's beep, 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 1, 2, 3, take it directly out, put it on the patient's bib, put it on the bracket table, and watch and see how much anesthetic comes out as the aspiration cycle finishes. If it's 1 or 2 drops, that's perfect. You're going to have excellent anesthesia. All the anesthetic went into the bone. But if you see 10, 20 drops, a steady stream of anesthetic coming out of that needle, then probably you're not going to have sufficient anesthesia, at least the anesthesia that you want, that should last approximately an hour. So in the next time, just do much lighter placement of the needle and holding of the needle in place. So then you go ahead and deliver the rest of the lidocaine, if you're using lidocaine, onto the mesial of the mesiolingual of the first molar, or any tooth except lower incisors, as I said, and deliver the rest of the cartridge of anesthetic. If you're using articaine, then you deliver another 1/4 of a cartridge on the mesial. Approximately 20% of the lower first molars get innervation from somewhere else, maybe from the long buccal or mylohyoid nerve. So I typically would give another 1/4 of a cartridge on the bifurcation area of the lower first molars only. Just 1/4 of a cartridge of either articaine or lidocaine should knock out 95% of lower first molars. What about if you wanted to anesthetize 2 molars next to each other? If you anesthetize the distal of the second molar, the mesial of the second molar, then skip the distal of the first molar. Do not double dose that area. Go to the mesial of the first molar. Okay, again, at 45-degree angle with bevel towards the tooth. Now you've anesthetized 2 teeth. And then I would also suggest delivering another 1/4 of a cartridge onto the buccal bifurcation of that lower first molar. That should numb up 2 teeth. To anesthetize a full quadrant, you could anesthetize the second molar with 2 injection sites, full cartridge of anesthetic. Skip the first molar and then go to the second premolar, 2 sites, distal, then mesial. It's very important to always start on the distal and then go to the mesial. Now you've anesthetized the whole quadrant. Sometimes you might have to give the supplemental anesthesia, maybe 10 drops on the distal of the incisors. Sometimes you don't need to. This is how we can eliminate doing infiltrations and eliminate doing the blocks, because we can use single tooth injection that's very, very efficient. It's very profound anesthesia that lasts about an hour. You can do any procedure that you would normally want to do on this tooth, and the patient would leave without their lip, face, or tongue being anesthetized. This is important to the patient.